let's give it a couple more minutes, and then we'll go ahead and kick this off. All right, Dr. Smith, I see you have joined us as well. Perfect.
How are you?
Good, good. Thanks for taking time out of your busy day. I know it's the end of the day for you guys, and you know, I think this is going to be a great program for everybody attending. And you know what? I think I'll go ahead and share my screen one last time before we kick this off. Is that okay?
Program, man.
Okay, it's official. We are kicking off this webinar, and I can't thank everybody enough for signing up and attending. So let me go through just a couple quick little housekeeping things. Let me share my screen real quick. And before we begin, everybody knows we are giving CE. So if you'd like to get CE for this webinar, this is what you're going to need to do. And these are the instructions here. At the end, we're going to give you the verification code. And if everybody's ready, I say we just jump right on in and start this webinar. We got a lot of great things to go over. I would like to introduce our main speaker, Dr. Paul Fugazzotto. It's a real pleasure. It's an honor to introduce Dr. Paul. Many of you know him. There's not nearly enough time for me to go through all the amazing accomplishments and books and articles and everything that he has really given to the industry. It's amazing. But as you can see, doctorate from New York University, and of course his advanced studies in periodontics from Boston University. Also the director of the Institute for Comprehensive Implant Therapy and Aesthetics. I've been to his facility. It is world-class. It's amazing. It's big enough, but yet small enough for that all attendees who go to his workshops will walk away with a tremendous amount of knowledge. So it's an incredible opportunity if you ever have a chance to go to Boston. And then also I'd like to thank TRI Dental Implants for helping put this all together. We couldn't have done it without you, with all the amazing technology they offer. So if it's okay with everybody, I would like to turn this over to Dr. Paul.
Okay. Just get rid of my echo. Go ahead, get it set up. You okay? Okay. Ready to go?
Let's do it.
Okay, so thanks. It's nice I've tried to support you to do this. And I also have a couple of colleagues I treat a lot of patients with, Doctors Smith and Folan, Folan and Smith, who are on here as well, that will get some expertise from. What I really wanted, what I was asked to talk about from Chris was basically how we use digital workflows in private practice. You know, I'm a full-time clinician. So what I show you has to work in a busy practice because we have a busy practice. So what I'm going to show you is honestly something we do every day. And it may seem at first like I'm not on the topic, but I am, because the point is that I have certain expectations of levels of success and ease of therapy with whatever therapies I perform for patients. I have certain expectations going to contribute to my patient experience and to transformation of my practice, which still continues after 42 years. So we're still constantly transforming. Like mentor Dr. Kramer used to say, if you don't significantly reinvent yourself after 5 or 6 years, then you're stagnant. So let's talk a bit. It's interesting because one of my former classmates just retired, and he asked me a very simple question. He asked me why I'm still doing this since I'm almost dead. Well, I'm actually not almost dead. It's true that one of my first patients was Julius Caesar, and I asked him not to go to the meeting to make a salad instead. That was his mistake. But honestly, I don't think we're dead. And I think that there's a lot to be done that's exciting, that keeps it interesting, that helps patients and helps us as well. So let's talk about it. Let's talk about how we use digital dentistry, but we're going to focus specifically on immediate delivery of single tooth provisionals today. We'll come parenthetically to other things, but we had to focus on something so as to not make this too lengthy, okay? So Again, it may seem strange, but first we have to figure out where we want to be. So you're going to have to answer this question for yourself. What is practice success to you? Is it having more patients? I don't know. Is it having more production, which is actually meaningless? Is it having more net income, which is more meaningful than production? Is it doing exciting things so you're interested? Is it something else? Is it less stress? What is it? You're going to have to decide. I can tell you now, we have no stress when we work. I mean, let's face it, all of us that are on here, when you get used to doing something, that's the easy part, right? So now you have to have your practice running in such a way that there's no stress from there as well. So let's look. I have certain demands when I have in my clinic and my clinical success and practice success. We know a lot of this is a given, but it sets the bar. Because if I can't reach this bar, I'm not going to use a technique. I'm not somebody who just adopts new things to adopt them, but I'm also not somebody who stays stagnant in quicksand because I don't want to adopt new things. Predictable treatment success is pretty easy, right? I mean, let's face it. It's an old statistics from my patients in perio, 3,500 of them, for example, with 40,000 treated teeth, 25 to 39 years follow-up, and they don't lose teeth because resective perio works. But even saying that, we do more and more implant therapy to help patients. And you can regenerate bone as much as you want to put these implants where you want them. You can get pre-pathologic bone morphology, predictably get 5 to 7 millimeters horizontally and 3 to 4 vertically without autogenous grafting. And doing the right techniques, you get nice, thick, crestal bone. We know this. So we know we can go from there to there in, 20 minutes? I don't know. Simple procedure with no autogenous bone. You can take this and turn it into this every single time with no autogenous bone in a physically and financially healthy patient. So we know this. So I have certain demands. I have certain demands that I do a lot of immediate molar implants, and we place them about 94.6% of the time that we take out molars. This is the mandible. And our success rate is the same as delayed. And if you've read the literature, published long-term studies with a few thousand implants, mean time and function over 10 years, and a success, not survival, success rate over 99%. I'm going to talk to you about success when we talk about digital dentistry, because when we do statistics, we bone sound every implant on the buccal or linguopalatal when we're compiling statistics. So it's Albertson plus bone sounding. So I'm only interested in success. I'm interested in taking this fractured second molar with this 2 1/3 unit bridge, and this guy paid for a 3-unit bridge. We're going to take it out and with differential pressure osteotomy, put them in ideal positions, not governed by the extraction socket morphology, and restore them. Anything I show you is well over 10 years. We know in the maxilla it's the same, right? Exact same percent, actually. It was interesting, 94.6%. Same success as delay placement, and we shorten therapy, of course. Focus on shortening therapy. Focus on shortening and bettering the experience for the patient. That's where digital dentistry is going to come in for me. It goes exactly in line with my philosophy, with everything else we're doing. Shorten therapy, make it more pleasant for patients, give them positive reinforcement, right? So I'll take out this fractured tooth, and I'm not worried about that abscess as long as I can place the implant in an ideal position. Of course, it's over 10 years. You have one with a narrower implant going into a narrower intraradicular septum. It works, right? However, that's not what we're going to talk about today, because therapeutic success is not patient success. I got out of my program, I trained with Dr. Kramer, and I get out very, arrogant. Of course, you get less arrogant as you go on. I got out arrogant. I thought I knew everything. And my father gave me a very good piece of advice. He was a small-time contractor, and he and I built my office. He said, it doesn't matter how good you are at something if you don't have anybody to do it with. So we're going to talk about how we use this digital dentistry to ensure that we always have a great patient flow of high-quality patients and working with very high-quality restorative partners. Okay? So patient success is much more expansive than therapeutic success, and that's what we're going to focus upon here. And that's, okay, I have no idea why that didn't change. Thank you. It's more cohesive, more fulfilling, and honestly is transformative. And more important than that, come on. More importantly than that, why is that doing that? Let's fix that. Okay, now we're going, okay, let's do that again, okay? Because it was fine a minute. Hit it, just hit them. Click, 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 and go one more. Now you gotta try and fix that. So let's talk about practice transformation with digital, just hit it, with digital dentistry. What are these patients looking for? What do your patients want? And then we're gonna tailor what we do to it. Well, patients don't want teeth. Patients don't want comfort. Patients don't want function. And patients don't want aesthetics. They take this for granted. It's like buying a car. I want an engine. I want wheels. No, you want a pleasant driving experience. What patients want simply is an optimal quality of life from the moment they see you throughout their lives. You know, whether you like Steve Jobs or not, and I have various opinions, he understood controlling and magnifying and improving the user experience from day zero all the way through. And that's what we're going to talk about. So let's see how we do it. So let's figure out first why they're saying no, because digital dentistry is going to answer these questions. Do patients refuse therapy because of cost, fear, time, pain? No. They don't refuse therapy because of any of these things. Never, 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 assuming the patient can feed their family. Patients refuse therapy for a very simple reason. Patients refuse therapy, get it? Because of lack of value. And that's it. So we have to instill the value, okay? Through utilizing a hedonic approach. It's not the time to talk about that. But very basically, you have to learn how to transform needs into patient desires. And then they will accept therapy all the time, okay? So our acceptance of comprehensive care is 94.3% with my patients. That's comprehensive care. That's not doing something. It's not taking this patient and sticking an implant in. It's comprehensive care, which for some patients may be a restoration, maybe a gingival graft, maybe not much. Some patients it's going to be reconstructive. But the key is comprehensive care. And the two restorative partners of mine who were kind enough to come on, and they're going to add a lot of input in a few minutes, have the same experience. And by the way, none of us are in these big hotshot areas, okay? And it doesn't matter. It works very well. So let's talk about how to do it. So this is my definition very simply. We're going to maximize outcomes, minimize trauma, address needs, and fulfill desires. Perfect for the digital dentistry we're going to talk about now, but perfect for practice in general. If you're not getting 93, 94% of your patients to accept comprehensive care, don't look at them. Don't look at competition. Don't look at politics. Look at you. The problem is you. The problem is what's going on in your office, and you have to learn how to do this. It's very important. So how are we going to use digital technology to impact our practices and our constant transformation? As an aside, not for any reason except to prove my point, Boston has the highest number of periodontists per capita of any city in the world, by far. If you flew to Boston, and the man who took your luggage may be a periodontist who can't keep a full schedule. I have no idea. That being said, there are 3 of us, and our problem is there are only 3 of us, seeing well over 160 new cases a month because of how you treat patients and the teamwork you make with your restorative partners. So let's talk. With digital therapies, the way I'm going to show them to you, albeit with single tooth and a couple of other things, not morphologic tonight, you can transform the patient experience. You can transform the therapies you perform, transform, your workflow efficiencies, which in turn, of course, increases dramatically your profitability. Your patient perception is different, as you'll see, and what that does for your practice. And your co-therapists, I'm a specialist. My perception of my restorative partners, their perception of me is different. This is the key to everything. So how do we do it? We all started very basically, of course, with full arches, starting to do planning and implant placement. This patient came in, and I'm going to show you an example and then take this same lesson and bring it to our single tooth. This patient appeared with these implants in his mouth. He'd been on amoxicillin for 18 months. He had an infection from the 2 days after the implants were placed. The dentist kept saying, the dentist who had probably placed, well, actually, I know he'd placed 12 implants before this in his life, kept saying, "You're fine, you're fine, you're fine." The patient came to me. And the problem is that he actually missed the bone with the implants. There's just enough bone to hold them. He's had infections here for 18 months. He's not a happy man. So we went in, we took these out, repaired the bone, and he looked like this. Now, Andre's a pretty big guy. And whenever I do better work, or else it's going to be very bad for my health. You'll notice back then when we did this, which is a long time ago, well over a decade ago, when you look at this, we're limited here. Fortunately, he's got a lower lip line, but when you look at what we've got for radiographs, and this just at the Panorex off of our CAT scan, we don't have a lot of bone we can take away. Those maxillary teeth are all decayed, periodontally diseased, etc. If we're going to do a hybrid here, we can't do a lot of bone reduction. Now, today, we wouldn't have to with digital dentistry. Today, we would do this case differently with what we do with FP1s. But even back then, first of all, I don't believe in 4 implants to hold a full arch, if at all possible, because you put 4 and 5 years down the line, something happens to one of them and you lose your case. So I believe that whenever possible, we try and put 6. So we take a look at Andre, and fortunately, that's his smile. But I can't take a lot of bone away here. I can take a little bit. Today, this would be an FP1 case. Back then, we didn't do that. And you took your software, of course, and you planned your implants. We all know that, and you put them in place. Now, here's the great thing about digital planning. You can get an implant anywhere. Here's the bad thing about digital planning. You can get an implant anywhere. The problem is that people throw away their biologic principles when they do this. We are not going to do that with what we're able to do today with digital technology. So you plan it, blah, 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 and you look at the case. And he's restored, and we're very lucky. Pure luck. That's his smile. Pure luck that we hid that margin. Today, as you'll see, we would never do that. I'll show you what we would do simply and quickly today, near the end of the presentation after we get through single teeth. And he was fine, he was happy, and that was that, except there was a lesson I learned from him. And what was the lesson with Andre? Well, the lesson with Andre was he had heavy parafunction. So we knocked a bunch of these teeth off. And now I am much more insistent on managing parafunction if you're going to do these cases, and we'll get to that and what causes them to fail. But I expect to do all of this with digital dentistry, and watch, it works. These happen to be the equipment I have. You're going to see Michael, Dr. Follen has different printer and Cura than Dr. Smith, but it doesn't matter. You'll get the one that works for you, and you'll hear their experiences as well in a moment. Okay. So Dr. Smith and I did this case a long time ago. It was digital, but in a different way. Basically went in, took out the teeth. It's against an upper denture. I put the implants in immediately. I took a scan right there. Dr. Smith sent to the laboratory. They sent back the final prosthesis, and it went in. And it was 36 hours. I'm sorry, I might have been 48. I might be wrong. I'm sorry, I just realized that. And it went in. Simple. But this is a very easy thing. It's against an upper denture. There's no parafunction. This is fine, but this isn't really what we're talking about tonight. Let's do something a little more challenging, okay? Let's look at single tooth workflow, and it's going to be very simple, okay? We're going to extract the tooth and put the implant in, if you should. And again, I'm skipping diagnosis. I'm skipping a lot of things. You've got a deep overbite, you're not going to immediately provisionalize this implant. You've got heavy parafunction that even with your management with neurotoxins, you're not so comfortable, you're not going to immediately provisionalize this implant. When you go to the socket, it's a whole discussion, which is not the time for tonight, a whole discussion of when to immediately place an implant, which is defect dependent, biotype dependent, surrounding bone condition dependent, soft tissue level dependent, etc., etc., etc. And then whether you immediately graft with it, what type of graft, and do you immediately provisionalize it? Do you use a membrane and bury it? That's a big discussion. So we're going to talk about the ones we believe we should provisionalize. I'm sorry that although I published papers, but that's a pretty big discussion for another time. That's not the purpose tonight. We take the tooth out, we put the implant in. Scan body goes in, my assistant Larry scans it. Then scan it again with the healing cap on. Bite scanned, posing arch, of course. We send it to Chris May, who designs it and gets it back to us. And Chris, I hate to put you on a spot, but we get it back in about 14 minutes. Of course, we let him know it's coming. He designs a single tooth and it's back. Bang. We get it back. The design is nested by Larry. Provisional is printed. Provisional is cured. Provisional is inserted. And what do you get at the end? Yeah, you get a provisional crown. You know what you really get? You get a missionary. You get a dental missionary, so it's created. That's what you get. You get somebody out there talking about what you're doing, and their friends are coming because of what you can do. This is the workflow. You'll see how fast it is. It's simple. There are a couple little places you can go with the printing. We'll get to that, okay? Here's one of the early patients I did. Tooth comes out, scan body in, scanned, healing cap scanned, provisional back, put it in, block up the hole, From there to there, 43 minutes. 43 minutes from sitting the patient up after the surgery to delivering the prosthesis. 43 minutes. Take a look here. The other tooth is going to be replaced, other crown afterwards. This is Dr. Folan's patient. Tooth's out with certain techniques. A socket has already is assessed. We find no surprises. We are going to graft here. It'll be a xenograft for specific reasons. Implant is in. Scan body's in. Provisional's placed. Back then we had limitations in the colors, although the color of the other crown's no good anyhow. 44 minutes to put the provisional in. From the moment the patient sits up. How long does it take to? So really, let's be realistic on this case. Okay, let's go back. So this tooth is fractured, but you take this crown off, you take the tooth out. How long did that take to take? Let's be honest. 6 minutes, 7 minutes, 8 minutes. How long does it take to take out a single rooted tooth and clean it out? Come on, it's like nothing, right? And it's simple. So the whole procedure from them sitting down to going home is an hour and a half maximum. Probably an hour, actually. Probably an hour. Because I only booked 30 minutes for the surgery. Hit that, please. We only booked 30 minutes for the surgery. Hit that? Okay. So let's go on. Okay? Take a look at this patient. Tooth's vertically fractured. Tooth out, minimally traumatic surgery. Look at the buccal plate to make sure this is the right thing to do. Of course, we've already looked at a lot of other things with this patient. Okay? There's a bone graft there. Of course there's. That's a xenograft because of the dimension and shape of the horizontal defect dimension. We use 3 different types of grafts depending on what we're doing. Okay? And that's the provisional in place. Again, color, we had limitations then. I'm sorry, 44 minutes. Should have said that, I apologize. 44 minutes. Here you go. This is one of Dr. Smith's patients. Patient comes in. Here's where I learn a lesson, okay? Very nice guy. Oh, I don't really clench out, but we've talked about this for years, and I was too soft on it. My fault. So we had implants in the molars that had been done immediately. Those are in function well over 10 years. Comes in, broke the bicuspid. Comes in. There's the implant in place with the provisional crown. To go from there to there, 43 minutes, and this is about 10 days post-op. I don't have one right. Sorry, my fault. Hit. Good. Right there. I'm sorry, that's 10 days later. I didn't have one immediately afterwards. 43 minutes. Now here's my lesson because of my stupidity. It's obvious this guy's got a parafunctional habit. I backed off, no offense, both Dr. Smith and I both backed off on pushing this guy about it. Finally, he comes back, he fractures the first bicuspid. I said, that's it. I said, I got to tell you the truth. I'm not treating you anymore unless you do what we want. This is ridiculous. You're going to become a dental annuity plan. You're coming in every couple of months with a broken tooth. You either need to let us do what we want or not. And I want you to, but if I'm going to start using neurotoxin to relax your musculature, I better find out what your sleep condition is, because I'd rather not kill you as I relax all your muscles and you can't breathe. So instead, I gave him a home sleep test with a mass of the leads, which we do all the time. Came back, he had no sleep apnea, it was purely parafunction, and we used neurotoxins. In his case, double the 2 heads here, the 3 heads here, internal pterygoid trigger points, and something here and here to relieve pain. All of a sudden, he was fine. But because I wasn't pushy enough, because I didn't do what I knew I should have done, and didn't see if we can fix this, will you please? He fractures the other one now. Now he fractured the next one, right? Thank you. Like so. So now we put it in, and we're going to adjust the equilibrate it, make sure it's out of occlusion because he bruxes like crazy. And again, of course, this was very quick and easy, 43 minutes. So the first lesson is, I don't care how good technologies are, if we don't do what we know is right, it's on us. It's on us. You know, I remember I see people, I got a patient came in, some gentleman had just put in 2 implants, and they both failed right away. He was trying to do a very hard case. He didn't have much experience. He told the patient it's because the implants were defective and she should talk to the company and get her money back. Then when the implants went, what was defective was his thought process. Okay, so this is very predictable and very simple. So I'm going to stop for 1 second here, if you don't mind, And I'm lucky enough to have both Tim Smith and Mike Folan here, and we both go at it a little differently. So I'm going to ask you not to talk even about the printing yet, but about the impact this has had. Michael, we've done a lot of these. The impact on your patient acceptance and your patient attitude after we do stuff like this. I don't have your voice. There you go.
Can you hear me now? Okay. Yeah, patients absolutely love it. They can't believe that they come in and they walk out with a tooth they walk out with a tooth. And we've done this all the time. And they just can't believe it. I mean, one case that actually came out of your office that you didn't do was Dr. Brodsky had a patient in, and the schedule got a little bit messed up. He gave me a call and said, I've got the patient here in the chair, and we've scanned it and sent the file to Chris May. Is there any way that you think you could see her? I said, sure. He says, Chris will have it back, what, in 15, 20 minutes? Send the patient over in an hour and we'll have the tooth put in. And it worked perfectly. And from what I understand, all she did was rave about how she couldn't believe that we were able to do something like this when she was afraid she was going to have to walk around without a tooth in her mouth. And she was just a happy person. It's just great. Everyone's happy.
Tim, do you want to add to that? Thank you, Michael. Tim?
Sure. It's been nothing short of amazing, honestly. Fortunately, when I started doing this, when we went to the fully digital 3 or 4 years ago, it's been a huge practice builder. That a large percentage of my new patients come because of this, and they appreciate the technology and how quickly things can get done and how much different it is than it used to be. And from my end, it's honestly the most rewarding thing I do, from a treatment standpoint also. So it's really a win-win.
Thanks. And we're going to go back and see how they have different workflows in a moment. And this really is the experience. You take a patient like this who's a very, very challenging patient who likes to maybe have some of your stomach lining, but we're going to put a new crown on the molar, section the prosthesis, take out the hopeless tooth, put in the 2 implants, put provisional crowns on them like so. And this is 48 minutes, a little bit longer because there were 2 of them. And she walks out and she came back, and she's a very serious patient, serious person. She came back for us to check her after, and she stopped. She said, you guys do something just like this. You guys do something different here. I'm telling my friends, this is space age. This is different than, and when they start telling people that, which it isn't, of course, they start telling, it's amazing. It's amazing, right? Again, take out the root, put our implants, scan them like so, and that's about 10 days later. And they're happy, and they're happy. So now comes the question, is what's the workflow? And I need to get both Michael and Tim back in on this in a moment, okay? Well, surgery's done, scans taken, the laboratory designs, and Michael, I'm very upset that Chris took 20 minutes to design this for you. He doesn't take 20 for me. I don't want to make you feel bad, but and we design it. Now, there are 2 possibilities. If the restorative partner does not have a scanner, although that's getting less and less, we print and insert the provisional. The patient goes in another room or sits out in their car if they like, or in a private room on a computer and just relaxes for those 40 minutes or so, okay? And we print and insert. However, the restorative partner has a scanner, they print and insert the provisional. Now, Michael has had a scanner, actually before me, he was using for a printer. I meant to say printer, I said scanner, a printer before me. It should have said printer, not scanner, I apologize. He's had a printer before me. So he was all set to do this. Tim began with me printing and inserting them, and now he prints and inserts them because it's a no-brainer for the restorative partner to do this. Gives them more, I'm so sorry that's a scanner instead of printer. Gives them more control, and also, no offense, not to sound mercenary, I'm not the restorative guy. I shouldn't be getting the fee for the provisional. The restorative person should. I would much rather my restorative partner does this step and gets the fee they should be getting. Why am I getting the fee for the provisional? And it works very well. Michael, do you see any, because we've done a lot of them where you print it, do you see any downside at all to them coming over to you to get it inserted?
No, not at all. It works great because you've seen the patient. They're just, you've scanned, sent it to Chris. They're not even out of your chair, and Chris has got the file in my hands, and I start printing. So they get over, you seat them. By the time you seat them and talk to them a little bit, everything is pretty much done, and you can insert. It's really great. And, the nice part is that they don't walk into my office and with, looking at getting re-anesthetized because you did all that work.
Tim, you've done it both ways because we started when you didn't have the printer and now you do. What's your opinion?
It's much better having the printer. I mean, you're more in control of the situation. As the restorative dentist, if there's changes that I want to make to the provisional, I can do that, right at that time. There's no question it's better to have the printer as the restorative dentist.
And we're going to get to this right now. So this is what I have. Michael has a Sprint Ray, correct, Michael?
Yeah, I have a Sprint Ray, I have a Prime Scan, and I have a Prime Mill too. Oh, well.
Okay, so basically, the question is it worth getting all this equipment, right? That's the question. Is it cost effective? So let's be realistic. I know what this stuff costs, as all of you do. If you in the United States, if you took a loan for everything, paid nothing down, and got the loans from the company with what they do for you, with the deals or whatever the right word is, if you already have a scanner and you just have to buy the printer, cure, etc., if you did 1 unit, which is either a provisional crown or a night guard, because we print our own bite appliances too, if you do 1 unit per month, that more than pays for all the printer, the curing, everything. If you don't have anything, if you're still taking analog impressions, if you're still riding a horse, I don't know, if you're still taking analog impressions and you have to buy everything, if you do 2 units per month, that more than pays for it. So that would mean 1 provisional crown and 1 bite appliance. And I don't know about you, but I believe that parafunction is the most underdiagnosed oral health problem that exists. And almost everybody has parafunction. It's a question if it's clinically significant in their case. We make a lot of bite appliances, use a lot of neurotoxins. I won't do a full arch reconstruction without first managing with neurotoxins their parafunction. They got this way for a reason. So is it cost effective? Well, dollars and cents it is, but you know what? That doesn't really matter, does it? What really matters, is it worth it? Is it worth the time? Is it worth the effort? Is it worth explaining to the patient? Is it worth changing your workflows? And then the money to buy the thing, which is the least of all of it. Is it worth it? Well, it does transform all of this. Our patients perceive us differently. My restorative partners and I have always had close relationships, and this has brought it to another level of interdisciplinary care and communication. Even if you're doing everything yourself, your patients will perceive you differently. So of course it's worth it. And the results are better. The therapy is better. You begin to form the soft tissues immediately. And as far as the workflow, please, it doesn't do anything. I mean, it takes Larry, I don't know, 7-8 minutes to scan the whole mouth and the bite or something. Then he sends it to Chris, nests it. We're working the whole time. We have 2 assistants. He'll be gone for that bit of time he's doing that. And we work in a pretty busy schedule, shall we say. I don't spend a lot of time fooling around in surgery. We get in, we get done, we get out. If we're going to do a full arch and I've got to take out now 10 or 14 teeth, and the periodontally involved ones are easy. The ones that are all decayed with a lot of bone are aggravating. But that whole surgery, including putting in the 6 implants, it's going to take under 2 hours, hour and 45. So even if you take longer, it doesn't matter. And then he scans, it goes out, and it comes back. I'll show you. It's easy. Look at this patient. This guy comes in. Okay. Yes, he's got other work to do on the bottom as well. Okay. This is what it looks like up top. These are all decayed, hopeless. I didn't even, that just went by itself. Why? Okay. Let's look.
Did you want the video?
No,
Oh, okay.
thank you. Okay, so here he is, right? We take these out, we put the implants in. You take your impression. Of course, we're going to do extraction, socket grafting, and grafting into the horizontal defect dimensions. You get the provisional back. Now this one, send it to Chris to design this or a full arch. Will probably take him about 35 minutes, which isn't so bad. Notice the emergence profiles. This is the old Preop Pros from Amsterdam and Cohen, from many others, from Nevin Skuru, from many, many more people, from Mani, from Boozer Bells, from everybody. Flat emergence profile. Comes to your contours a millimeter submarginally, so it doesn't evert the tissue and send it apical, supports the tissue, and soft tissue actually fills in where that space is and gives you thicker soft tissue. And there it is in place. 98 minutes from sitting up from surgery. Not from sending it to Chris, from sitting up. That does not include putting the scan bodies in, taking the impressions, putting the healing caps, sending it out, getting the design, scanning everything, getting the design back, printing, inserting, everything, 98 minutes. Now, it's much more to it than that. And I'm just showing this almost as a, what can you do? There's so much more detail to talk about, of course, because, for example, we don't use photogrammetry. There are things that we use with Chris that are much better and much that's wrong, much easier, much simpler, and much more versatile. But again, another discussion for another time, because that wasn't the purpose tonight. Look, and it's in. Look at this fellow. Those are all decayed, those upper teeth. And this is very interesting, right? Because, I trained in a different era. So we're sitting there, and the restorative dentist is here, and my youngest associate is watching too, and say, okay, you got to get this bridge off the top. It's like, oh, you got to cut it. I don't have to cut it. It's all decayed. You're taking out a bridge removal, it all comes off, right? I guess they don't do that much anymore. Comes off. Implants are in. Grafting is done. Scan bodies are in. Boom, boom. Look at this. Look at this. He's happy. He's happy with that provisional. He walked out with it. He is now a missionary, and he shaved. He shaved his mustache. He didn't like the way his teeth looked before. It's easy. It's simple, and it's predictable. Practice transformation is fluid, not static. It's constantly evolving. There's not a defined envelope. I hate the term practice growth. What practice growth means is that you've got these numbers, and when you hit them, you're fine. So it's like having a great stallion. If I can get to the end of the field, I did great. You want to go beyond the field. You want to do what you can do. That's what practice transformation is. You build scenarios. You look at things that aren't even anticipated, and you figure out what to do with them. You take some risks, but they're grounded risks. I am not a funambulist. I'm not a tightrope walker, right? Come on. And there are innovative solutions. So what it comes down to is, who are we? We have two choices. Two choices. Are we passengers or are we captains? That's what it's going to come down to. Digital dentistry has changed what we do, and to give you a sense of the impact, and I still do 5-6 hours of surgery a day, I'll say whatever, but we do at least one immediate single tooth provisional every day. We do large amounts in our office of hybrids, or whether you're FP1, FP2, or whatever the fancy terminology is now. I think there's too much conventional hybridization going on, where all this bone is ripped away. I see these cases where they take so much bone away that now they can't even get back into these second bicuspid positions. And they've got these angled 4 implants. No, thank you. I spent 30 years, 40 years trying to figure out how to get things straight with bone grafting. I don't want to take away this bone if I don't have to. Bob Jaffin 15 years ago was taking teeth out, putting implants in, taking the analog scan, and within 36 hours delivering a fixed provisional. Now we can do it right away. So sure, we do conventional hybrids with taking away all the bone, but we do a lot of FP1s. We do a lot of basically crown and bridge on immediate implants with digital provisionals, because it works, because it makes a difference. And these single teeth transform things. So my friend John said, why am I doing this? I'm almost dead. My question to somebody who doesn't do this is, why aren't you doing this? Are you almost dead? Is the way I would, go ahead, the way I would do it. So to quote my chairman, Dr. Gerald Kramer, my mentor, I would say to you, our definition of success is limited by our perception of possibilities. And I would also remember that every patient is an event. We decide what we're going to do. I'm not dead. and this is what I'm doing. If you're not advancing, then honestly, you are clinically dead and emotionally dead in dentistry. And as far as excitement, it's done. You know, you're going to get carpal tunnel counting money. That's not that exciting. So that's basically what we're doing. Chris, I'll turn it back over to you for questions, comments, tomatoes, anything. But if you don't mind, I'd ask both Michael and Tim if they had a sentence or two they wanted to say in summary of their own, succinctly. Michael?
You pretty much said it yourself. I mean, you and I are basically the same age, and I love what I do right now. I don't think I'd still be in dentistry if it wasn't for bringing in all the technology and starting to be able to do something different and seeing what the patients, how happy they are that we're able to do what we do. It's great. You're right. Having a printer, doing all the scanning, it's just the way to go now.
Tim?
I'm just a kid. I'm only 56, but this has still been, it's still been, were you muted? This has still been a transformative thing for me. I mean, not to give Paul a bigger head than he already has, but he basically was the driver behind me getting all this stuff 4 years ago. I was an Improgum guy for 25 years, and I haven't, since I got the scanner 4 years ago, I haven't used Infogum one time. No one misses it. The patients, obviously, me, the staff. It basically transforms your practice. And let's face it, dentists, we also like gadgets. It just keeps you interested and motivated because the stuff, for lack of a better word, the stuff is pretty cool.
Thank you. Coach, before we take questions, I have to say, and I really mean this, that, you know, this would not work like this without Chris. His willingness, his accessibility, his flexibility, and honestly, his knowledge. I mean, he's dragged me kicking into a lot of these areas that I would have delayed much further. I am just so glad that he's out of prison again to help us, you know?
Well, it was all the help that you provided, and really all these workflows. Every time I do a case with these fine gentlemen, I learn something different, and we apply it to the next case and the next case. And if you could get in touch with this group and really spend time with them, even up in Boston at their courses, you'll be able to go 0 to 60 so much quicker than trying to do it on your own, because they've been there, they've been through all the heartaches. And working with them, we developed so many different protocols, like having 2 email addresses. Believe it or not, it's important. So when I get a design done and I send it to Dr. Folan or Dr. Smith, and they have an email account, and let's say that email account was tied to a team member, and maybe that team member didn't make it in that day, and no one remembers the password. Well, now we have a backup email address. So little things like that. It only takes a second for us to just key that in and send the file right on over. So also knowing which printers they have, that helps us out a lot, from designing and our capabilities, and to be able to offer additional services to them. Maybe they don't have time to nest it. Well, if we know their software, their printer, we may be able to nest it for them. So a lot of great things that we were able to come up together, and it's always evolving, and we're always pushing forward. Like Dr. Fugazzotto said, why get to the end of the track? We want to go beyond that. So every case, these gentlemen, that's their approach. Let's go beyond. Let's see what else we can do. Let's not just do the bare minimum. Let's go beyond. So I can't thank you enough to allow me to be a part of this and really just absorb everything that you 3 are doing. It's an incredible journey.
It's fun. It's a lot of fun. If you have any questions you want us to answer for anybody, I don't know.
Yep, we have a few questions already lined up. One of the attendees is asking, hey, great presentation. How does the implant, the TRI implant, make a difference? That's one question we have right there.
You saw some Straumann implants and you saw some Tri implants done.
Mhm.
And I've obviously got a lot more experience with Straumann, but we've done enough Tri for me to know about it. And I know enough about it, I think. I guess you can never know enough. It's got some advantages. You don't have to have an abutment. You can do a lot of interesting angle corrections. I do leave the implants slightly longer before loading to final because it's SLA, not SL active. But that being said, that's just a few more weeks. It works very well with both. There are some advantages to Tri not having an abutment, which saves you some space as well. And they both work great. That's an honest answer.
We have a question that maybe Dr. Follin or Dr. Smith, what do you charge for a digital provisional?
We're talking, so just a single unit?
Yeah, let's just focus on the single implant restoration. Dr. Paul
Yeah,
had placed it and then sent them over to you for
Right.
restoring.
yeah, and it's not a temporary crown, or obviously we're not calling it a temporary crown. And the patient wouldn't know what the word provisional meant. So I basically tell them it's a healing crown. It's basically so that they understand it's helping to shape the tissue. It's so they have more. It goes back to what Paul was saying about value. I charge between $500 and $600 for a single unit provisional.
Excellent. Excellent.
We charge $495, so you're in the same range. Somebody's going to ask this next question. A bite appliance is $595 because somebody's going to ask that. Michael, are you in the same range? I know that you're a very haughty-toddy type of guy. I mean, what are you charging for the provisional?
No, I'm basically in the same range, maybe a little bit less, but a lot of times I incorporate it into the fee of the entire thing. So when they're coming in it's another way to look at it is they're coming into the office and you're doing all this extra work and they're walking out with a tooth and and they haven't pulled out their checkbook to give you something for that provisional, even though it has been completely incorporated into the price of what we were doing. They're happy with that too. So it works.
Dr. Paul, this is a question directed towards you. Do you treat any of the New York Yankees?
I feel bad doing that because then when they go to hell, my stuff is going to burn. No, actually, there's not that big. Since both the Yankees and the Red Sox are lousy now, it's not so bad, But I lived in New York City when Bucky Dent hit the home run, which was a very bad thing. So I do treat some Yankees. I just don't use any lidocaine.
We have a question about making it temporary for a patient here. So do you have any problems with patients who are temporized that function on the provisional, and how has it affected the long-term success of the implant integration?
Excellent question, because this is a problem that we had to evolve in how we were handling this, okay? So we talked about parafunction and having to manage that. But, I used to just say to the patients, don't eat on this, it's a provisional, it's for looks, and then it would be fine for some, and then somebody would come back, and it would be split in half, and they'd say I was drinking soup. So you know how that is. So now we're at the point, honestly, to make sure they don't do it, that what they sign says that if they chew on this, that will cause the implant to fail and the provisional to fail, and they will have to pay for the whole thing all over again. And now that has solved it. Because we had a real problem with this. Because if they do chew on it early, they're going to screw things up, for lack of a better word. Now, on a full arch, of course, that's different. But on a single tooth, it's a problem. We spend a lot of, I'm not an implantologist, and neither are Tim and Michael. We try and do comprehensive care. We spend a lot of time with occlusal analyses, with rebuilding lost tooth structure, with using appliances or treating parafunction if we have to. But that's the warning we give, because they will wipe it out, and it's never their fault. So I don't say it might happen. I say it will happen, and the problem has disappeared. I get sick of having to deal with it. And we have one patient, as you know, Chris. We did a full arch provisional. A week later, he split it. Gave him a new one. One day, he split it. I said, Bill. And he came and said, what's going on? I said, you're not parafunction. I can see that. He said, well, I golf a lot. And every time I do, I know I chomp down my teeth real hard and I hear it crack. I said, well, now you're paying for the new provisional. And if you do it again, then you're going to keep paying it, and we're not going to make the final till you can go 6 months without breaking it. And he finally stopped. It was ridiculous, you know. But no, it's a real problem. You have to be right up front and tell the patients, here are your ramifications if you don't do this, period.
So we have a couple more full arch questions, but I know some attendees probably need maybe think about getting going and stuff. So the code that you're going to need, if I could share my screen real quick, it's going to be TRI. And let me just zip through this real quick. If you do the code TRI, you will get your credits here. So capital T, capital R, capital I is your code. Excellent. Okay, back to those full arch questions. You know, one attendee, they wanted to know, okay, so you have 5 or 6 implants. How do you determine whether the whole implant benefits from 6 or 5 units crown and bridge, or make it separated as having 3 and 2 unit? Basically, if you have 6 implants, how do you determine keeping them all splinted together or making them individual bridges?
You're talking about a full arch?
A full arch.
No, I would splint them all the time. I don't see any advantage any advantage to not splinting them. I mean, you know, you're going across the arch. I think that cross arch splinting is valuable, and I would splint them all the time. If I'm doing individual implants, say first and second molar up here, I don't splint those. But coming across an arch like that, I would splint those. Yeah.
And I mean, certainly when we're doing these immediate loading cases, you know, there's a big advantage to having the cross arch splinting, you know, because of the potential patient compliance or lack thereof.
Yeah. We did have a question about, somebody didn't see any drill guides, any like pilot guides or surgical guides fully guided. Are you commonly using digital drill guides?
So here's a really honest answer, because I'm a really straightforward person. I think that there's no shame in using extensive guides. I think there's shame in not using them when you should have. And I mean it that way. There are some times that I use guides. I don't do fully digital where I've got stops to drill to depth, etc., because I don't find, how can I phrase this? I don't find that particularly useful for me, and I don't find it as accurate with exact positioning of depth that I want as people say it is. I mean, I've done like 45 or 46,000 implants, not in the same person. And single teeth, I should be able to get exactly where I want as I want them. The others, because you can do angle correction for full arches, a lot of it's getting into very good bone coming out the right way. If I'm doing an FP1, I'm going right into the sockets. So no, I would use it if I felt I had to. And my partners use them more than I do. I'll do it occasionally, but not that much. And that's a very honest answer.
This might be
but there's no excuse for. No excuse. Good.
This might be a great question for Dr. Smith, who recently just started printing and is up and running, making his own provisionals. They wanted to know, with printed provisional crown, what material would that be? And what is a protocol to add material to the provisional crown for tissue sculpting if you needed to, you know, maybe push a little bit more on the papilla and you want to add something to it? First, what is the printed material you're using? And second, what would you use to bond to that material to add on?
Yeah, great questions. Yeah, the printed material, I mean, there's a variety of different resins out there, many different brands. It's just the standard resin temporary crown and bridge material that they're all very similar and easily accessible. And for any kind of tissue sculpting, you're able to bond composite resin to this material, and it holds fine. That's been my experience.
Excellent.
Regardless, even though the temporary is technically a resin, you can still bond composite to it.
You know, I think the other part of it is learning what, you know, Dr. Paul's doing chairside, setting the case up, and then what Dr. Smith or Dr. Folan, their expectations on how to push or manipulate that tissue. That's where the design comes in. You heard Dr. Smith say earlier, hey, if I see something I don't like, I have the ability to change it. So if anything, we're communicating on the fly about these cases. And sometimes we'll be like, hey, do you want me to push on that? And he'll be like, yeah, why don't you push on the tissue? If it's too much, I'm going to take it back. I can easily take it off. I can easily put it back on, but set it up for ideal. If I see it being too much, I can easily just carve it back. It carves like butter.
The key
And
point
that's where,
sure, you'll have to do it sometimes, add to it, but you really shouldn't have, especially in these single tooth ones, you shouldn't have to do that much because you should be able to see exactly what you want for it. And that's where Chris comes in, and or if Tim's designing it himself, etc.
Yep.
right, and that's where I was just going to say, with the pre-op planning, even on that 6-unit case that Paul showed earlier, there was no change to the provisional that had to be done because of the pre-op planning and the great design from Chris.
It all sets up with the stage that I'm given. I have a great, implant placed. I have tissue management. I have a great scan. And just overall, I know their expectations. So that's the one thing that we've learned right from the get-go, is establishing that line of communication, but then also making sure Dr. Paul's scanners, Dr. Tim's scanner, they're all talking to each other, and we can easily send files back and forth. We're not doing this on the fly where, this is the first time. Before the patient even hits the chair, we're setting up our scanners together to make sure they can see me and I can see them. We've established an email communication back and forth. Where does that file need to go? We know what kind of printer and materials. And also, real importantly, we need to know what do they have in their office as far as like the type of either temporary cylinder, tie base, the screws, the tools that they have. All that plays a big factor. And we did that all ahead of time before we start, touching patients. So that way the whole patient experience, as well as the team's experience, we got to maintain that. And we don't want to, there's enough stress going on. We don't want to add anything else on top of it. So we work those problems out ahead of time.
You just said, and this is not meant to be self-serving at all, you have to realize what we're doing here is doing a little overview together. Whether it's with us, whether it's with somebody else, wherever you go, it's a lot more than just pull a tooth out and put the implant. Like anything else, the examination, diagnosis, and planning are the key. And that's what takes time to really delve into in different examples. So that I don't want you to think that any of us, Chris, myself, Michael, Tim, any of us think that we just gave you some comprehensive thing, because we didn't. Because if it was this simple, it wouldn't be worth anything. And there really is a lot of planning and diagnosis, etc. So I'm not trying to say we're so great, but somewhere you have to go and really put this in context the right way. Wouldn't you guys agree?
Completely.
Absolutely. And looks like we got one last question, and they're talking about the future of dentistry. They threw out an example like 5 to 10 years. Feel free to change that from 2 to 3 years, because it's changing so fast.
Yeah. What?
Oh, did you get muted?
I didn't.
There you go. You're live.
What happened here? Can you hear me?
Yes, I can.
Okay.
Now,
So was that the whole comment, just that it's faster than 5 years?
They wanted to know, like, what you think, in the future, the crystal ball, what do you think 5, 10 years is going to bring?
A lot more good wine, but no, that's not what you were asking me. Okay. Well, a couple of things now. Number one, I don't think the basic thing that's going to stay the same is the following sentence, I believe. You do the best you can. You treat people the way you want to be treated, and you explore all possibilities and use them to think ahead yourself and build scenarios and adapt. And that's just how things work, right? I remember I used to take these lectures. Oh, you're going to go to a boutique practice. What, are you kidding me? You just treat people the way you want to be treated. What do I see? I don't see it becoming where one person does everything. I don't see DSOs taking over the world, which is what everybody talks in the United States. What just happened? Did we just get killed?
Nope. Somebody wanted the code.
And I don't see, honestly, the loss of individuality. I believe that the future is going to be more and more digital, of course, more and more provision to patients of therapy in simpler and simpler ways. Bone regeneration for things I can't talk about right now because of non-disclosures is going to come much easier and much more rapid, where you're going to be able to put an implant into material, and in 30 minutes, you're going to be able to load it permanently with a removal torque of like 70 Newton centimeters, restorative materials, etc. All that's going to happen is it's going to get easier and more predictable. But you know what's going to become more important? Is going to be appropriate examination, diagnosis, and treatment planning. Because you know what I do every day? I see at least 2 patients a day where I'm fixing stuff. Not because the person who did it wasn't adept with their hands, because they didn't do appropriate diagnosis. So I see the future as more actually individual dependent, more diagnosis dependent, and then the therapeutics themselves are becoming simpler, faster, and more predictable. And that's our challenge.
We have another question here about how do you avoid billing insurance companies for these full arch cases? They asked, do you use high-tech consent to avoid billing insurance for these cases, including full arch?
I don't know what high-tech consent means, so I'm not sure what that is. I can tell you, you can't bill for full arch because it's impossible. You know, the patients know that we're not accessing their insurance for this. The truth is, in the United States, you've got a great plan. Was it $1,500 a year? Okay, so this is going to be $32,000, and you get some coverage. Maybe it's not going to make or break the case for them. And sure, if they've got insurance, we don't belong to PPOs, but if they've got some other insurance that they'll pay some of it, sure, that's great. But that's not usually something we look at. Our therapies are not insurance driven. That's not because I think I'm so great, because I'm not. But the point is, I've always told a patient what I thought they needed. I didn't care what their insurance was. And then if you give them the value, they'll figure it out. Sure, we'll send it in and use up your insurance on the extractions. There you go. That just helped you. It'll go to you because you have to pay us when we do the work. That's what we do.
Excellent. I believe that answered all the questions we had. And again, for everybody participating for CE, the code that you're going to need is going to be TRI, and that is all in capital letters, TRI, like the implant system. And, you know, I cannot thank Dr. Paul, Dr. Smith, Dr. Fullen enough to jump on and kind of give us a teaser about this workflow. I would encourage you to look these guys up and check out some of the courses they offer in Boston. It's a great time. It's so easy to get to the Fugazzotto Institute. It's really, I mean, maybe 30 minutes from Logan Airport. I mean, it's not bad at all. And I've made that run a number of times. And it's a wonderful place. And doctors are they're so open. You can ask any question, and they will guide you and they will tell you. So a big thanks for everybody. And I know they're going to do a follow-up after this. So you look for this on Monday, I guess, because of the holiday. So check your email boxes for additional follow-up. And again, thanks to Dr. Paul, Dr. Smith, Dr. Michael Fullen, and TRI for sponsoring this. Thank you so much. And I wish everybody a great weekend and a great holiday. Thank you again. Bye now.
Thanks, Chris.
Bye,
Good night.
everybody. Take care.
Good night.
Good night.